Start the recording. All right, welcome everyone to the Wayside Women's Wellness Echo. If this is your first time attending a WWW Echo, welcome. A little bit about Project Echo and Wayside Recovery Center. First off, Wayside Recovery Center is located in Minnesota. We're a treatment facility and we provide mental health and addiction treatment services for women, children, and families. Project Echo, which stands for the Extension for Community Healthcare Outcomes, is a movement to demonopolize knowledge and amplify the capacity to provide best practice care. So together, we have the Wayside Women's Wellness Echo, which is 1 hour long at noon each month. I know somebody said that they were eating their lunch right now, so oftentimes over people's lunch hour, and it really is meant to be a sort of lunch and learn style series. And the goal is to share practice and support service information, which will hopefully enable participating organizations to empower all people in recovery and empower women and families to break the cycle of addiction and trauma. My name is Zora Darcourt. I'm the Director of Training at Wayside Recovery Center. And today our Echo session is entitled Foundations of Harm Reduction. Our speaker for the day is Shannon, and let me get your last name here, Shannon Curry-Izzo, who is will also be our presenter for the next 2 upcoming Wayside Women's Wellness Echoes, and will additionally be presenting on hepatitis C basics and motivational interviewing for people who use drugs. So that's coming up in the near future here too. A little bit about Shannon. Shannon was born and raised in Buffalo, New York, and completed her master's in clinical mental health counseling and began her work in harm reduction in 2013 by working in a syringe service program. It was here she offered low threshold counseling services and eventually specialized in injection counseling and care of injection related injury. Following her presentations at the National Harm Reduction Conference in 2014, Shannon began collaborating with the NHRC as a consultant and has assisted with a variety of projects, including curriculum development and technical assistance. These national collaborations were often centered on the areas of safer injecting, overdose prevention, pregnancy and drug use, infectious disease such as HIV, HCV, and STIs, medication for opioid use disorder, and numerous other topics. In 2019, Shannon transitioned to the position of clinical trainer for a local CCBHC, where she took special interest in creating space to educate clinical staff on harm reduction as a movement, philosophy, community, and represented outside of academia, something she hopes to continue working towards on a much larger scale. Shannon began working with the National Harm Reduction Coalition full-time in September of 2022 as a training and content development coordinator and continues to pursue completion of her license in mental health counseling. So we're really happy to have you, Shannon, and I will pass things over to you. Thank you. Welcome, everyone.
Thank you so much. And I just really want to highlight what Zora had mentioned. For those of you who are here on your lunch break, you're amazing. You didn't have to be here. You chose to be here. And as somebody who frequently skips lunch to attend trainings, I just want to say I deeply appreciate it because I know how hard it can be. So thank you. Also, to Minnesota, I recently, a couple weeks ago, got back. Our agency did a big partnership with Avivo, who's doing some really incredible things. So they're really doing some great harm reduction work. If you ever want to reach out to them and get more involved with them, especially around housing and things like that, tell them Shannon sent you. But Minneapolis is an amazing city. So thank you for being here. Okay, so for those of you who might not be familiar with the National Harm Reduction Coalition, I used to kind of affectionately refer to it as kind of the mothership of all things harm reduction. It's been around for a while. It was actually first started as the Harm Reduction Working Group in 1992. And we still have quite an active group that has been affiliated since the beginning of the organization. Some of the key players that were involved in the initial organization, that Harm Reduction Working Group, were names like Dan Bigg, who we have to thank for overdose prevention programs, community-based overdose prevention programs, Dave Purchase, who's kind of our godfather of syringe access. So he was over in Washington State. Edith Springer, social worker in New York City, who really helped bring harm reduction to the clinical social work side in the early 90s. Yes, we've had some really incredible folks sit in our office and help create this incredible movement moving forward. So we do a lot when it comes to policy and advocacy. We have folks throughout the entire country in many different states that are working with local governments, working just improving policy, pushing back on harmful policies, things like that. We have our national and regional conferences. So we just had one last year in Puerto Rico. If you ever get a chance to attend, I cannot recommend it enough. It is a truly amazing experience. Thousands of people go to these conferences. It's probably one of the only places you'll sit alongside a therapist, a district attorney, an active sex worker, somebody in recovery, somebody who's still currently using. It's just an amazing group of people. We do a lot of training and technical assistance. That's how I'm able to come to you folks today. And with our overdose prevention, we really do a lot with getting programs set up around the country to streamline and start their naloxone programs. With Zoom, I'm not going to go too much into this. I think most of us are probably very familiar with Zoom by now, but please feel free to pop anything into the chat. I'm going to do my best to kind of monitor it. There will be opportunities for you to engage. It's a relatively small group, so if you, well, I shouldn't say that. Oh, that number jumped pretty quick. I take it back. But if you do feel moved to unmute or you want some clarification on something, please just go ahead and do it. I'd rather you have your questions answered in the moment rather than wait to the end, forget what you wanted to ask. And chances are, if you're thinking of a question, somebody else here is also. When it comes to what I hope that you all leave here today, I hope that you will have a good understanding of the principles that harm reduction is founded on. We do have principles. We have central tenets that we abide by. And I really want you to have a chance to think about which ones resonate with you and which ones challenge you. And not just which ones challenge you, but let's start thinking about how you can reduce some of those challenges, tangible things that you can do. We're going to talk about different harm reduction intersects, and we are going to look at different ways that we can engage folks who use substances who might be in that pre-contemplative, contemplative stage of their use. So somebody who has no intention of quitting, somebody who is maybe a little bit on the fence about it, what can you do in terms of harm reduction options? Okay. Harm reduction overview, right? The workshop overview, we're going to get into defining harm reduction. We're going to talk about what it is, and we're also going to talk about what it is not. There has been an incredible PR push in the past 5 years, I would say, to start embracing harm reduction. And that has a twofold kind of consequence. On one hand, it's fantastic that this movement that people, especially in the drug using community, have been asking for decades is finally getting a voice. And at the same time, I have also found that there are some pretty strong misconceptions around what harm reduction really is. So we're going to talk about what it is. We're going to talk about what it's not, how it can benefit public health. Then we're going to get into those principles I talked about. And then we're going to talk about unpacking harm. Harm is not universal. Harm is incredibly subjective. So we're going to talk about what harm looks like, and then that to get you kind of thinking about where some of the opposition and some of the challenges come when harm reduction enters a conversation. Why are we okay with some interventions and maybe not so much when harm reduction comes into play? And then we're going to wrap up with some strategies that you can, some relevant approaches that you can utilize, that you can refer people to, and then some other things that you personally can do to align yourself more with the movement. All right, so I have up here, what is harm reduction? I'm wondering how many of you here have heard the phrase meeting people where they're at? You can just raise your hands. Yeah, meeting people where they're at, right? So in a smaller group, I might encourage you all, or if you want to play along now, go right ahead. But I'll often encourage people to think about, how do you operationalize harm reduction? What is your definition for harm reduction? And what used to happen before I would put up this slide, I'd say, tell me what you think harm reduction is. And it was almost uncanny how common this would be. I'd go from person to person, they'd say, meeting people where they're at. Meeting people where they're at. Well, you're meeting people where they're at. we're going to where they are and we're going to meet them there. And I said, okay, got it. Okay. So if I were to say, how do you define harm reduction? And you can't use the phrase meeting people where they're at, how would you explain it? And suddenly it would get very quiet. Or every once in a while, somebody would say, well, you know, if they, wherever they are, we're going to meet them there. And I would say, changing the wording doesn't change that. We're not really getting a more cohesive definition. So why this is important. I have come to find out that for folks who haven't really been exposed to harm reduction, and you might see this in your work as well, there can be a tendency to reduce it to this singular phrase, meeting people where they're at, without really understanding what that means, without really understanding the philosophy behind it, without understanding the movement that it was built on, the individuals, their stories, their experiences, the policies, all of those different things. You don't have to have a completely 100% strong understanding of all the different nuance that I just talked about. What to try and get people away from is that talking point, that singular talking point. Harm reduction is so much more than meeting people where they're at, and it's not a bad phrase. It really isn't. It becomes a negative phrase when we're not explaining and exploring what that really means in everyday practice. So there are some strong definitions. You have them right here. These are ones that were initially developed by the Harm Reduction Working Group all the way back in the early 90s. And it still stays. We still use these definitions. So when we're talking about harm reduction, we're talking about practical public health strategies. We're talking about strategies that range from safer use to managed use to abstinence. And I saw something in the chat, the harm reduction versus abstinence debate. It's very interesting to me because harm reduction and abstinence can absolutely be congruent goals. 100% can be congruent goals. I can only speak from my experience. I've worked in different clinics as a therapist. I still do. I've worked in a syringe service program. I've worked on the policy side, the training side. And all the different people that I've worked with, whenever I've seen somebody come into my office who is struggling with substance use, and maybe it's really chaotic, whatever the case may be, and they say to me, you know what, I think I need to go into treatment and I don't want anything. I don't want any medication. I just want to go into treatment and come out and just be abstinent from everything. If that's their goal, that now becomes my goal. And I will do whatever it is I can to help facilitate that. However, I have never seen somebody wake up with that intention and all of a sudden say, you know what, I don't want to do this anymore. I'm good. I don't know if anyone else has. I can't speak. I haven't met every single person who uses substances. I just have never seen that. So when we're talking about harm reduction and abstinence existing together and being congruent goals, I like to think of harm reduction as filling that gap between somebody's ability to achieve that goal, their willingness to achieve that goal. This fills that gap. So when it comes to disproportionate rates of infectious disease, what we're talking about is folks who are disproportionately affected by HIV, new cases of hepatitis C. It used to be baby boomers who accounted for the majority of hepatitis C cases. The new cases, the overwhelming majority is due to IV drug use. And if you're not really sure why that might be, or you have questions around that, please come to the next training because I'm going to get all into it. We also can see this play out in real time. We've seen cases in Indiana, we've seen cases in West Virginia. And also prior to the inception of syringe service programs, you're going to see the acronym SSP a lot. Prior to the inception of SSP, syringe service programs, in the early 90s, we saw about, I think it was around 67% of new HIV cases were due to IV drug use. After syringe service implementation in certain states, I can speak about New York State, the percentage of new HIV cases due to IV drug use is around 4%. That is a massive reduction. And then of course, lastly, it meets, accepts, it engages people who use drugs, that acronym PWUD, people who use drugs on their own terms. Harm reduction really was designed to be almost zero threshold, not just low threshold, almost zero threshold. So let's talk a bit about how to parse out the little h and the big H. With the first one, that little h, that little r, it's a behavior. It's a thing. It's a thing that people do. There's no great philosophy behind it. So for example, what that might look like, I bite my nails. It's true, I do. We can all agree, I think, universally that biting nails, especially during times of COVID, there's a level of risk associated with that, right? Hands tend to touch things, they're dirty. I'm not washing my hands before and after every single time. There's potential for infection. There's all different things that can happen when somebody bites their nails. So to mitigate that risk of all the negative things that I just talked about, I started using no bite. And no bite worked a little bit, and then I realized I could bite through it, so that wasn't going to work for me. So then I decided I'm going to maybe leave one finger alone, and then maybe I'm going to leave the next finger alone. And as long as the behavior is not exacerbated, I'm not biting the other fingers more, that is considered harm reduction. But I'm not doing it because there's a greater philosophical reason. I'm just doing a thing to reduce negative consequences. Now, when we're talking about harm reduction, that capital H, capital R, that is your philosophy. And this is something that is very deeply rooted in activism. It's rooted in a deep respect for people who have engaged in these practices. I'm talking about drug use, sex work, pretty much anything that carries a level of risk to self or community. This philosophy really requires us to look at the human being for who they are as opposed to who we want them to be. We listen to those folks and we take their lead with unconditional positive regard. So we also have to acknowledge, if you identify as that capital H, capital R harm reductionist, I'm not saying you have to, I personally do, but if you do adopt this philosophy, it also kind of requires of us to look at those populations, marginalized populations that have historically been treated as patients, have been treated as not exactly productive members of society. We are elevating them to people who have and acknowledging their very real contributions to public health and overall wellness. And I'm going to demonstrate that as an actual fact in a minute. Let's talk a little bit about that philosophy and practice. So when we're talking about harm reduction as a philosophy, we're looking at acknowledging the autonomy of human beings. People do things for various reasons. Nobody does anything for no reason. Even if we say that I'm engaging in a behavior because I'm bored, that's a lack of stimuli. There's always a reason for why people do things. And some people do risky things for different reasons. My perception of what is risk might also very much differ from somebody else's perception of risk. So harm reduction really comes in, again, to fill that gap between when a person is willing to make change versus when their circumstances allow for it. And what I mean by that is, let's say you have a person who comes to you and says, you know, I've tried everything to stop using. I've done the medication. I've done all the things. I need to get away. I need to go inpatient. I need to get out of here. Anybody ever hear that story before? I need to get away. I need to get away from all the people, places, and things. Okay, great, wonderful. That person is very willing to make that change. However, let's look at the circumstances. Who's going to watch their children? They're the sole provider. Their insurance might have some serious limitations. There might only be one treatment facility, and it might be very, it might not be conducive to that person's gender identity. It might not provide services in that person's first spoken language or their language of preference. So the circumstances might not allow for it, and that's going to be a problem. Now, let's say somebody is mandated because of an ongoing court case. There's law enforcement, there's court involved, they're mandated to treatment. Well, the circumstances certainly allow for it. And yet, if that person is not willing, maybe this is a fourth, fifth time, that's going to be really hard to make meaningful behavior change. So what do you do in the meantime? That's where harm reduction comes in. It also acknowledges that human beings have something called dignity of risk. And I'm not sure how many people are familiar with that phrase. Anybody hear that before? Steve, I appreciate your comment that oftentimes someone's substance use, whatever it may be, there's often other issues at play. Yeah. So dignity of risk in a nutshell is basically understanding that people have the right to do things that you or I might not necessarily agree with. They have the fundamental human right to make choices that I might not make for myself, I might not want my children to make for themselves, but human beings have that fundamental right. So that's again where harm reduction comes into play. I might not agree with what you're doing on whatever level, and you have that fundamental right to make decisions that I don't necessarily agree with. That doesn't mean I'm going to stop treating you like a human being. That doesn't mean that I'm going to stop trying to help give you options and help you improve your education so that you can make informed choices. Harm reduction is truly one of the most unbiased, objective ways of approaching working with somebody, because you are truly taking them at whatever they're presenting with. Harm reduction also, it really empowers us as providers to view these sometimes challenging behaviors, these behaviors that we might have some moral, ethical, whatever it may be, concern about. It allows us to view these behaviors through a much more humane and compassionate lens. So again, that bridge between willingness and ability, and that in the meantime. When I was still working at the syringe service program, I was also in grad school at the time, and I was watching some of my peers who were going into different clinics, and they had only been in clinics for maybe a couple months, and they were already getting burned out. They were already referring to the revolving door. They were already using language that was not okay. And where was this coming from? I couldn't understand why I wasn't experiencing that in the syringe service program. I was seeing clients all the time who were presenting with some really complicated concerns. And I think the difference was being in that syringe service program, practicing that radical harm reduction, really allowed me to see people at their most authentic. I was not asking anything from them. They were coming and holding space with me simply because they wanted to. And that is such a unique, privileged position to be in. And I recognize that's one that not everybody is in a position to do. I have really tried, though, in working with therapists and other providers to help them see the benefit in building rapport, that unconditional positive regard, true unconditional positive regard, and allowing people space to feel, to say that they don't feel safe, to say that they don't trust yet, and allowing that to happen instead of rushing people to, let's just work on treatment goals. Let's just do this. Let's just do that. I can conceptualize harm reduction. This actually came from a keynote address that Professor Jerry Stimson made a couple of years ago. If you're not familiar with Jerry Stimson, harm reduction really kind of, as we know it today, really began in the Netherlands in the 1970s. And it was very much in response to the hepatitis B outbreak. So in the Netherlands, prior to this unionization of drug users, there was an attitude that if we saw you out on the street, if we saw that you were somebody who used drugs, that we had to force you into detox. And detox in the 70s, we know detox nowadays is not great. Back in the 70s, it was significantly worse. And the treatment outcomes were incredibly poor. So there were a group of individuals who basically said, look, this isn't working. We have a right to live. We have the right to sterile equipment. And maybe if you did that, we wouldn't be in the position that we're in right now, watching each other die and get sick and get skin and soft tissue infections and all those things. So they formed the first unionized group of people who use drugs. They were called the Junkie Bund. You can look this up. It's a fascinating study in how people absolutely can come together, unionize, and get their needs met. And around the early mid-80s, I should say, Professor Jerry Stimson was a researcher with the British government, and he was tasked with going to the Netherlands to find out why they had been able to keep their numbers so low in hepatitis B and this new virus that we were just starting to learn about that we now know as HIV. So Professor Jerry Stimson went out there, studied what was going on, mind blown, came back and essentially wrote the first article that establishes the evidence base behind syringe service programs and a harm reduction approach from 1988. The research still holds up. If anyone here has ever done anything in academia, you know that looking at research from the 80s is not best practice. I can tell you, though, this research still holds up today. He actually was so invested in harm reduction because of his experiences. He went on to develop and co-edit the International Journal of Drug Policy, and he was one of the first chairs of what is now Harm Reduction International. So they're kind of our sister agency in Europe. But I really love this idea here that harm reduction is also based on respect As Scott Burris once said, it is the opposite of hatred. And Scott Burris was an attorney who really kind of fought for housing justice. I love this idea of respect as the opposite of hatred, because I have seen people do some harmful things in the name of, quote, love. I'm doing this because I love you. I'm doing this, you know, you can love someone. I think you can love somebody and not respect them and not respect their choices. But this harm reduction really kind of really is meeting somebody and saying, I don't have to have all these other emotions around what you're doing. I just respect your autonomy. And it really is the opposite of hatred. So we talked a little bit about what harm reduction is. Let's talk about what it is not. So here are some of the different things that I've heard over the years. These are real statements that I've kind of plugged into different presentations and decided, you know, maybe we should streamline this and kind of fact check it in real time. So one of the first things people would say when it came to syringe service programs is, well, that's the reason why there's so many overdoses. That's the reason why there's so many people who are using drugs. You keep putting up these programs, and we see this variation when things like safer consumption sites come into play, or overdose prevention centers come into the conversation. That's not how this works. Syringe service programs are actually quite hard to get up and running, and they are very reactive. They're often, I've never seen a proactive syringe service program. They usually start popping up when a crisis hits. This is also part of us having a much larger conversation around why there is the presence of fentanyl, why there's the presence of xylazine, why prescription drugs are being misused, and things like that. It's also not the reason why there are so many needles on the street. So one of the big things that we would often hear when it came to having syringe service programs, new ones being implemented, was, well, if you put one here, people are just going to throw their needles on the street. Actually, there has been significant research that shows that when a syringe service program is in an area, there's a higher likelihood that syringes will not be disposed on the street, that they will actually be properly disposed, because people actually have somewhere to take them. And then it's also not making our communities more dangerous. Harm reduction programs, syringe service programs, they do not make communities more dangerous. There's actually no difference in crime rates in areas that have syringe service programs or harm reduction centers versus those without. Oftentimes though, and again, this is where we have to practice information hygiene, syringe service programs are often put into areas that are very high impact because we want them to be accessible to people who are engaging in these different behaviors. And it's often going to be an area that already has something going on there. It's not because of the program, it's in reaction to what's already happening there. It's also not a way for people to avoid personal responsibility. I got to tell you, working at the syringe service program, I have seen people walk in incredible heat. It's Buffalo. I know you in Minnesota know winters. I have seen people walk in the winter just to dispose of syringes and make sure that they had sterile ones. They would go back, make sure their entire communities were taken care of so they didn't have to share, so they didn't have to reuse. It's incredible what I've seen people do to try and take care of themselves and their communities. And also, don't forget, the very act of accessing a syringe service program, it demonstrates a willingness to mitigate the harms that can come with some of these behaviors. If people didn't care, they wouldn't be there. They would use a syringe that they found on the ground, which is what people do when there is no place for them to access sterile supplies. And it's also not keeping, quote, sick people, quote, sick. So we know, again, from research that a majority of the referrals that come out of syringe service programs are to recovery programs. It's also a major place for people to get HIV, hepatitis C, and STI testing, not only the testing, but the treatment and care that they need for those. There's also many programs out there that function as hubs. So these hubs often have people come in that can assist with obtaining insurance, education, housing, higher medical care, you name it. These are incredibly wonderful organizations to embed in communities where sometimes it can be really hard to engage folks who are engaging in these behaviors. It's also not restricted to Narcan and syringe service programs. I've talked about SSPs a lot, and that's because when we're talking about harm reduction, it is inextricable from syringe service programs, because that's really the framework that we're working from. And really that was, harm reduction came out of the response to the HIV/AIDS crisis, and that came in by way of access to sterile supplies. So that's why I talk a lot about the SSPs. It's also not restricted to naloxone, and why I want to mention that is I've definitely seen programs say, we are very harm reduction oriented, we have a harm reduction philosophy, and yet they are discharging people for engaging in the very behaviors that brought them there. They have very punitive policies, but they're giving out Narcan. Giving out Narcan, giving out buprenorphine does not a harm reduction program make. They are things. They are little h, little r. You can give somebody medication for opioid use disorder and do it with complete and utter disrespect for that person's autonomy. You can give someone Narcan and do it in a way that they will leave your office feeling completely worthless. So these are things. We need people to do things. We need people to do the little h, little r, and we can't forget that harm reduction is not just these things. We really, if we're going to start calling ourselves harm reduction programs or harm reductionists, we have to remember what else comes with that, and that's the philosophy. We also have to make sure that we are giving people education on HIV, hepatitis C, and STIs, that we know how people can dispose of their sharps safely, that we're offering people case management for their services, that we are offering a multitude of referrals for all types of different things, yes, including treatment, and what else is that person struggling with that we can assist with. As to the need for harm reduction, we also have, we talked a little bit about responding to the disproportionate disease and fatality rates. With that also comes folks who are dying from opioids, with folks who are dying from contaminated and adulterated supplies. We want to make sure that harm reduction programs exist so that they have a safe place to go for access to testing strips, for real information, for a safe place, yes, to use so that they're not out on the street. We also want to be able to reach those vulnerable populations that oftentimes, for one reason or another, are not always successful in traditional programs. And of course, when individuals relapse, because we know that relapse is a very common thing that happens, that they are not completely pushed away and get an epic case of the efforts. I know you all know what I'm talking about. It's the, I've relapsed, so what's the point in going any further? We don't want that to happen. So harm reduction programs are a really great way to retain some of those folks so that if they do relapse, they have a safe person to talk to about their use, that we can help hopefully prevent getting any other infectious diseases. It's important to recognize that relapse does not have to be the end of somebody's recovery path. And that's where harm reduction steps in. I love this quote. If you've never seen this quote by Maya Angelou, please write it down, commit it to memory, take a picture. But every once in a while, somebody will ask me, okay, thanks so much, Shannon. That was great. You told me all the practical stuff about harm reduction, but how do I actually do it? And that's a really hard question to answer, because ultimately what I have found is if you practice the principles that we're going to talk about in a minute, you naturally practice harm reduction, because your mind will start thinking about how you can honor what that person's goal actually is, as opposed to what you want it to be, or they're telling you because that's what they think you want to hear. But what it really looks like in practice, people will forget what you said, people will forget what you did, but people will never forget how you made them feel. So if you treat them with disdain, you treat them with disgust, you treat them like they don't know what's best for them, you treat them like their experience is invalid and you know better, that is how they will feel. So with the harm reduction approach, just to reiterate, it goes on, it's a spectrum, right? So we have safer techniques, we have managed use, and we have abstinence. So sometimes safer techniques looks like a person who has no intention of stopping. And this is a true story shared with permission. I had an individual, one of the first people I started working with, who was injecting about ½ an ounce of cocaine a day. It's about 30 injections. And they had no intention of stopping. So I said, okay, all right. You're going through a lot of syringes. What are you doing with them? And they said, well, I'm staying in a motel, so I just throw them in the garbage. Well, you know what? What do you think would happen if the person who's cleaning your motel were to get accidentally stuck? And kind of watched them mull it over, and they were like, well, yeah, I wouldn't feel good about it. And I said, okay, well, can we figure out a way for you to get your syringes back here? And they said, well, I'm not carrying around one of those giant red bins. I said, fair enough. They're pretty obvious, right? Sometimes people don't want that obvious indicator that they're carrying around biohazard material. So I said, would you take, like, I don't know, this? And I had at the time, I had like a muscle milk jar with some kind of protein powder. And I said, would you take this and put your syringes in there? And she said, yeah, I guess. So I dumped out the protein powder in the Sharps container, gave her the empty protein thing. And lo and behold, the next day she came back with it. It was completely full. So that was one harm reduction measure that I was able to take for somebody who had no intention of stopping. Let's make sure that you are disposing of your Sharps in a safe way. Not only that, but she, for some reason, had this idea that she can only take 10 syringes at a time. And I said, you don't have, you know, there's no limit on it. And she said, well, how many can I take? And I said, well, let's look at it like this. You inject about 30 times a day. How many times do you actually puncture? That was multiple times a day. And I said, I'm going to give you a box of 100. And she was like, really? And I said, well, yeah. So this was also helping to reduce skin and soft tissue infections. This was helping to reduce track marks. And that's incredibly important for somebody like her who at the time had some chronic health conditions. And we needed to maintain some kind of venous access in case they needed healthcare, which absolutely happened. Then there's that managed use where somebody maybe says, you know what, I might want to cut down a little bit here. I don't really want to touch this over here. I want to be able to use and just make sure that I'm not going to overdose. Okay, we can do that. We can talk about fentanyl testing strips, xylazine testing strips, whatever you'd like. And then there's abstinence. So again, if somebody says to me they want to stop using, they want to get into AA, NA, whatever their goal is, my goal is now their goal. Levels of harm reduction. I want you to just kind of look at this quickly. We're going to go over each one, but I just want you to look at this quickly and maybe pop into the chat. Knee-jerk reaction. Which ones do you think really speak to you, that you think you do really well? And maybe which ones challenge you the most? And I'm going to revisit this with you. Maybe something that you can do to make that a little less challenging, but knee-jerk reaction, and then we're going to revisit this. Oh, you know what, Teresa, I would just want to uplift what you said. Thank you so much for sharing that. I once read an article and it talked about the word enabling. And the writer of the article said, you know what, I'm going to take that word back. You know what, next time somebody tells me I'm enabling people, I'm going to say, you're right. I enable them to reconnect with their families. I enable them to take care of their health. I enable them to get tested. I enable them to get treatment. And I always thought that was really lovely. Okay. So hang on to some of those thoughts. My hope as we go through these different principles is that many of you are going to be terribly bored. Why? Because hopefully these will feel like common sense. So when it comes to health and dignity, we really are just looking at how somebody's life is being affected, not only on an individual level, but as a community level as well. And we want to make sure that our policies reflect how that person is going to be impacted as an autonomous human being and the impact that it's going to have on the community. That simple. With participant-centered, this is where we offer services that are non-judgmental, they are non-coercive. And we are really looking at targeting somebody's individual needs with what they're telling us they need instead of what our preconceived goals might be. So you tell me what you need, and I believe you. With participant involvement, I think the best way to conceptualize this one is nothing about us without us is for us. So this really says to be a harm reduction program, to be a harm reductionist, however you want to conceptualize that. We cannot create policies and programs and say that we are doing our best if we are not actively looking for feedback from people that are going to be impacted or utilizing these programs or impacted by these policies. So if you have created a program or you're running a program and you have had no participant, you've had no patient client feedback, that's a problem in terms of harm reduction. So this really, again, think about it in your own lives. Nothing about us without us is for us. It's a very important part of this because harm reduction was given to us by people in the drug using community, not the other way around. We are only now as a society catching up and realizing, they were right. And yet I consistently see that folks who utilize these services are pathologized, looked down on, and treated as though they don't know what's best for them. When in fact, the only reason we're here is because of that wisdom. Participant autonomy, you are the primary agent of change. I want you to be empowered with information, and I want you to be able to support others in your community. I want to give you information that is not inflating risk or downplaying it. That's a big part of harm reduction. And to kind of piggyback off of that, we are pragmatic and we are realistic. We don't minimize harms. We don't inflate them. We treat everything as is with the information that we know to be true today. That information might change down the road, and that's okay. It's okay to change your mind. But right now, I am being honest with you, the person who's coming into my office, about what I know to be true right now without resorting to fear tactics. There's sometimes, especially when I would tell people what I did, I was an injection counselor. And people would say, so you teach people how to do drugs? And I said, well, I mean, if you want to reduce it to that, that's the Cliff's Notes version of it. But it's actually so much more than that. I'm teaching people about their bodies. I'm looking at their rituals. I'm teaching them relaxation techniques. I am seeing their self-harm scars. I am seeing things that they haven't showed people in ages because they're scared, because they're shame, whatever it may be. But my job in that moment is just to hold space with that person and give them the ability to feel safe talking about the one thing that everyone else is telling them that they can't. And of course, sociocultural factors. So we have to recognize that there are so many different things that make people vulnerable to these different types of harms. Someone's socioeconomic status, poverty, trauma, race-based discrimination, misogyny, transphobia, all those different things impact somebody's vulnerability to and capacity for engaging in behavior-related harm reduction techniques. So with that, I want to show you a quick video. This is our North Star statement, because one thing at the Harm Reduction Coalition that we want to be very clear on is that part of the reason why why harm reduction is getting such a big PR boost and so many people are taking an interest in this is because of the demographics that are being primarily focused on. So by that, I mean white people who have used prescription drugs. It's a notable shift from how drugs and policy was treated back in the 80s. So we have to remember as we move forward that racialized drug policies still exist. We have so much work to do. And while we are tackling the opioid epidemic, we cannot leave behind communities that have historically paid the price of racialized drug policies, disproportionate sentencing, and things like that. We are capable of walking and chewing gum at the same time. We absolutely are. We don't have to pick one over the other. We can continue to move forward with the opioid epidemic, and we can look at how meth is affecting populations. We can look at how crack is affecting populations and so forth. So I would like you to hear from some folks who are involved in this movement.
The first time I heard the North Star statement, I was completely floored because in such a short space of time, with such a short statement, I felt that it applied to my whole life.
The North Star statement is that the Harm Reduction Coalition creates spaces for dialogue and action that help heal the harms of racialized drug policies.
I heard the North Star statement. I felt incredibly seen.
Un documento que habla directamente acerca del impacto del racismo.
North Star statement acknowledges the fact that the U.S. government made policies and laws to police and harm people of color.
The drug policies in America are deeply racist.
He's deeply racist.
And so we need to be able to accept that and understand that and not be scared of that.
The North Star Statement recognizes that the war on people who use drugs is an intersectional issue.
The statement recognizes the need for action and it recognizes the need for healing.
I think it's really important to say it and to commit to it out loud.
I got really lucky because I have an immense amount of privilege, and I have a lot of options and a lot of choices that didn't get taken away from me, regardless of my drug use, because of that privilege.
The North Star Statement means to me is about giving back to the community.
In line with meeting people where they're at, but not leaving them there, that means that we need to focus our energies on meeting those communities that have been marginalized, left aside, silenced.
Bringing people together and having a dialogue.
Not to only have dialogue, but the Harm Reduction Coalition to be one of the agencies to actually address the systemic issues that create the marginalizations and discriminations within our state community.
The North Star Statement is a commitment to change.
This may be hard for some of us to hear, but the harm reduction movement is not immune to institutional racism, no matter how allied we believe that we are.
The North Star Statement is a promise on Harm Reduction Coalition's behalf
to undo these policies that grew out of a totally socially unjust racist background.
To keep a focus on how people of colour are most impacted by the war on drugs so that we can maintain that at the forefront of all the work that we do.
We're not just fighting to advance harm reduction interventions. We're fighting to address the root causes that lead people to be vulnerable to drug-related harms.
The North Star Statement means to me that I work in an organization that has the commitment to address racism head on.
It may also involve conflict, but we shouldn't shy away from that conflict. Without conflict, we can't grow.
The North Star Statement is a way forward. It's hope. It's being acknowledged by the people that I work with and alongside in a way that I feel like I haven't ever been in any other movement. So I guess it means everything.
The first time I heard the North Star.
Apologies. Any thoughts you can pop into the chat? That's our North Star Statement. Yeah, it's really our commitment to keep in focus that we still have a lot of work to do, truly and honestly. And we cannot let opioids, because of prescription drug use and because of the mass deaths of people who look like me, drive this attention and drive all the other interventions, because we leave so many people behind. It is a great start, and we are only one organization. And that's why we need everybody. That's why we get this message out there, because we can only do what we can do. But if other organizations continue to kind of operate from a perspective of harm reduction equals opioids and opioids equal white suburban, we're going to have a big problem. And that is how, unfortunately, many organizations still do operate. So we have to continuously have these conversations. It's going to be a work in progress. It's not going to get solved overnight. Yeah, Steve, I couldn't agree more. We still have to deal with stigma and shame. And in the spirit of harm reduction for our own community and our own society, I'd like to think that a majority of us are contemplative. I'd like to think that. So in the spirit of that, what can we do to continue to move forwards? And that's really going to be for you all, because you know your communities best and how to have that conversation. That's incredible, Bobby. And Native Americans are another population that is constantly getting left behind in conversations about this. So we are hopefully going to be having more Indigenous focused harm reduction toolkits coming out and things like that. We've partnered with some really amazing organizations, because just in the spirit of anything else, if you are not a person in that, if you're not a person that identifies in that population, you don't have a whole lot of business writing curriculum for it, right? So hopefully we will have a lot more stuff coming out. Stay tuned. Or if you want to reach out to us, Bobby, we can always be consultants, just saying. All right, so let's do really alliances. And as we start to get to the end of our presentation, I want you to really think about some of those principles that pose a challenge for you. There's got to be one or two. But before you leave here today, I want you to really think about it. Have that internal conversation with yourself about what makes this so hard and what is one thing that you could maybe do to make it a little less challenging. Alliances, I was very surprised when I first started getting into the clinical world. Everybody was on board with trauma-informed care. Everybody wanted to talk about it. And I thought it was fascinating because these were often the same people who had some pretty big opposition to harm reduction. So I actually decided to look at it one day and say, you know, these principles seem awfully familiar. So I went through and I kind of put them against each other, and they are very similar. This is a harm reduction alliance. In fact, I could be so bold as to say harm reduction is inherently trauma-informed. I don't know that trauma-informed is inherently harm reduction, but harm reduction is inherently trauma-informed. So let's talk about those kind of different intersects. Harm reduction sits at the intersection of so many different movements, but here are some of the big ones. Racial equity, having fair housing, sex work is a really big one that we do a lot of work with. Our LGBTQNCR, transgender, nonconforming folks, reproductive justice, healthcare, decarceration in young people. Those are all the different intersects that we have to consider when we are having a conversation about harm reduction. They don't exist in silos. And please keep in mind that harm, it is subjective. And some of this too can be cultural, some of this can be learned. And oftentimes it's just from a person's individual experience and what they're observing in their own peer groups. What somebody's personal experience might be with consequences versus what I'm saying could be a consequence. If somebody is saying to you, if you keep doing that, this is going to happen, but you've been doing it and that thing hasn't happened yet, there's not going to be a huge motivator to change, motivation to change. And that motivation to change gets even less when we start having that person look at other people in their trusted peer group who have been doing that thing and they're still okay. Now there's many different reasons for that, and that might not actually be an accurate portrayal of what's happening, but to that person, their perception is just that. So somebody might not perceive HIV as being harmful. And I've absolutely had people say that. They're like, well, you can take a pill, you'll be okay. And that can be a really tricky conversation. Or with hepatitis C, well, you know, it doesn't really affect people. There's a cure for it now. It's okay. So that's where I always kind of go back to symbiotic goals. And if you come to the motivational interviewing training, I'll talk more about that. But we have to really meet people where they're at. And sometimes that is understanding that what I perceive to be harmful is not universally shared. But we do have to be aware of something called harm displacement. So whenever we're talking about having a conversation around harm, we don't want to make assumptions that we are not inadvertently putting someone in harm's way. And a good example of that is, so this would often happen when we would refer people to inpatient treatment, especially somebody who came from extreme poverty or food insecurity, assuming that because they had been through treatment programs before, that they were going to be able to navigate this successfully, didn't do our due diligence, and made assumptions that they would be able to navigate this as well, and only to find out that they got discharged for, quote, stealing food because there were such heavy restrictions on getting access to food. That is setting someone up for failure, and that is harm displacement. We're trying to do a good thing, making assumptions. And then, of course, a lot of times harm is subjective because people don't have the education around it, and we have to give that in a very culturally informed, kind, compassionate way that really encourages a sense of self-efficacy and focuses ultimately on that person being able to make an informed decision for themselves. Why are we not always okay with other things? Because harm reduction, it really doesn't demand that we do anything that we aren't already doing for other folks. It really doesn't. It's just that substance use can be a really tricky thing because of laws and moral judgment and things like that. But we have to remember that there's no such thing as a perfectly worthy person. Sometimes that moral judgment and personal experience can lead an individual to take some very strong stances against things that they don't really understand or are looking at through a very biased lens. Please don't run from these judgments when they happen. We have to run to them. Where is it coming from? Who am I hurting with this? How is it being sustained? But we can't pretend that we are non-judgmental people. Human beings, we're judgmental. It happens. Every time you make an assessment, every time you sign off on a clinical note, you're making judgments. It happens. There's positive judgments, there's neutral judgments, and there's negative ones. And when those negative ones happen, please don't pretend that they're not there. No good comes from that. You do not grow from that. So here are some other forms of harm reduction for you to peruse a little bit. Yes, syringe service programs is the one that we really talked a lot about. And there are a lot of other ways that we practice harm reduction that people don't really typically think about, but harm reduction truly is around us. It really is in so many different ways. Everything from condoms, birth control, to insulin, blood pressure, cholesterol meds. When it comes to mental health, if you have somebody who is engaging in self-harm, those distress tolerance skills, I almost fell out of my chair when I first started learning about DBT. I'm like, that's harm reduction. Doesn't call it that, but that sure is what it is. Strategies for survivors in domestic violence situations. Letting a baby cry it out is harm reduction. So we have our NRTs, we have scheduled titration, we have our standard MOUDs, so methadone, buprenorphine, naltrexone. And then when it comes to public health, designated driver programs, seat belts, anything like that, hand sanitizer. With harm reduction services in particular, though, here are some options that you can give anybody, regardless of where they are on that change spectrum. If they're using substances, having a partnership or knowing where that person can go to get sterile supplies. So it might be syringe access, it might be just safer drug use supplies, it could be testing strips. We also want to make sure all folks have access to overdose prevention, so you know where to get, you know where to send somebody if they want naloxone. You have been trained in it yourself. Medications for opioid use disorder, where can you refer somebody? How can they get condoms? How can they get access to PEP and PrEP? Safer consumption sites, we've talked a little bit about. They're a little controversial. We can have a discussion about that, though, if anyone needs to. But drop-in centers, housing first programs, and of course, referrals. All of these different services, and there's a lot to choose from. All these different services can be provided to somebody regardless of where they are on that change spectrum. So what can you do? You personally, what can you do? I put up this little, the little QR code here because as critical as I have been loudly about some of the things that SAMHSA has done, one of the things that I do appreciate they did was they, for their treatment improving protocol around cultural competency, they did add in a pretty decent section on drug using culture and recovery culture. Also did some really good revising with military culture too, just putting that plug in there. But what we really want you all to do is engage in that compassionate curiosity, not cultural tourism. We are not expecting the folks who come in to educate us simply because we're curious, because they're doing a thing that we're unfamiliar with. That is not our business. We are there to practice cultural humility. We also want to make sure that we trust that lived experience of people who use drugs and might engage in different types of sex trade. These communities, the drug using community in particular, I can't overstate it. They gave us harm reduction. It was not the other way around. So next time you have somebody in your office who might be making some questionable decisions or might have some feelings, just remember that given the opportunity, that person could be a potential revolutionary. And I've seen it happen. I've seen people be incredible change makers in their communities after being discharged from program. Believe grievances. Believe people when they tell you something bad happened. And please, please emphasize building a solid rapport that does not require the person is always honest with you. Oftentimes, there are so many experiences that lead to distrust in these communities, and we cannot expect people to just give us, unyielding trust the first time that they meet us. And then incorporate peers, pay fairly, and practice information hygiene. Don't fall for clickbait. Please don't fall for clickbait. There is a pretty strong campaign that is being launched around the country with very faulty information to not uplift harm reduction services and put out some very questionable information that's just not accurate around places that are doing some really great harm reduction work. I saw iPhone has a hand raised. I don't know your name, iPhone. I'm so sorry. Or not. With that is our time. I know I went through so much with you folks, and it's probably right at the end of your lunch period. I just appreciate you all so much for being here and holding space. I will hang back for a few minutes. Also, if you wanted, you can always reach out to me. Here's my email address. Sometimes this is just a better way to engage if you do have some bigger questions or something that you just want to debrief. Y'all are doing amazing work, though. Thank you from the bottom of my heart for being here and just doing what you keep doing. Go raise some hell, change the world.
Thank you so much, Shannon. For folks who need CEU, I'll be sending out a survey probably early next week. And on that survey, you can let me know if you need CEU. That's how I figure that out. And then if you can just give me like a week or so, I'll get those certificates out to folks. Shannon will also be our next presenter for our next Wayside Women's Wellness Echo, which I'm really excited about. That's going to be August 3rd. And I will send out registration info for that. That's coming soon as well. But I know some folks have to jump off. I don't know if there were any last questions. Shannon, I didn't know how much time. I heard you say that you were willing to hang back a little bit.